Namaste, everyone. Welcome to the Cārvāka podcast. This is your host, Kushalmehra. All right, today's topic is titled Ayushman Bharat and its viability for private healthcare players. So, just to give you guys a brief background as to why we are chatting about this, a few days ago, I had also coincidentally read a similar article in the Times of India. It was titled Ayushman Bharat not viable for private healthcare players. This was 12th of December, and Dr. Amit Thadani had also read the same article and co-tweeted it. So I reached out to Amit and I told him, Amit, ek kaam karte hain. I think this is a very important subject and let us talk about it. And Amit, as always, is kind enough to come on the podcast. So Amit, thanks for coming.
So, thank you for calling me, Kushal. And it's always fun to be on a podcast with you. The discussions are quite meaningful, and you know, we get something both ways out of it. Nice.
All right, Amit. So let's start here. I know sometimes people go under the assumption that obviously people must be knowing what Ayushman Bharat is, but I am going to start this podcast with the assumption that the viewer of this podcast does not know what Ayushman Bharat is and why we are analyzing this very specific scheme and policy of the government of India. So my first request to you, Amit, is please explain to everyone who's going to be either listening to the audio version or going to be watching this video version, what is Ayushman Bharat?
So, Ayushman Bharat is the world's largest mass health insurance scheme as of now. And basically, it's got two components. One is the National Health Protection Scheme, and one is the Health and Wellness Centers. Okay, so the idea is that the National Health Protection Scheme takes care of the admissions and indoor requirements, and the Health and Wellness Centers take care of the outpatient requirement. Mainly, and concentrate on health and wellness along with just primary care treatment. Right now, what the government has done in this is basically they've taken an earlier scheme which was called Rashtriya Swasthya Bima Yojana, RSBY, what it's called. This RSBY was launched initially in 2008 with the aim of, uh, creating exactly what Ayushman Bharat has actually created. That they said that we will create a hospital network. There will be an insurance company which will pay the bills of the patients who are treated under that network. And they had a target of empaneling about, just let me see, uh, so around 5 or 6 crores. They had initially said that this is the amount of families that we are going to cover. Now, under this scheme didn't work well. Okay, there are hardly about uh, you know 12,000 hospitals. Initially, all enthusiasm hospitals rushed into it to join the scheme, and within 5 years, most of the private hospitals had left the scheme. We'll come to that later on as to why this happened. And the target beneficiaries were around 6 crore families, as I said. That 6 crore number was expanded by a huge amount to about 10.74 crores under Ayushman Bharat. And uh, the coverage as far as RSBY went never really rose, and the maximum they could achieve was about 62% of the coverage, which means just around maybe 3.5 crore families could be enrolled under it. As opposed to this, Ayushman Bharat has eliminated the problem of enrollment completely by using the 2011 census as basis for automatic enrollment. So anyone who is BPL on 2011 census automatically is on the list. I know 2011 census is outdated as of today, but automatically the enrollment problem was completely eliminated. But by default, everyone is on it. And later on, even they expanded it further by integrating these lists with the state. Each state has its own health scheme, so to speak. So to expand it further, the government further made it more flexible. That okay, we integrate PMJY with your existing state scheme also, and the central government will pay most of the funds in that. Like for example, about 60-40. So 60% of the funds actually come from the central government, about 40% come from the state government. But in the hilly terrains, northeastern Himalayan states, and in the, maybe you can say, Delhi, union territories with legislature, 90% of the funds come from the center and 10% from the state. And those who are complete union territories with no legislature, 100% funding is from the state, or from the center only. And that's basically the model onto how it goes. Now, the structure of Ayushman Bharat has got two options which were given to the states, that you can adopt either of two options, right? You create a trust, you appoint fund managers basically, and the funds which will be coming, like 60% from the center and 40% from the state, will come into a trust, and the state will manage that trust. Basically, the premiums which are collected will be disbursed to the beneficiaries who are applying for the scheme, based on the requirements. The other option was, the insurance company will step in. Insurance company, the state will pay the insurance company to the premiums, and the insurance company will do all the management of the policies. So these were the two basic things. Many states initially opted for the trust model, and later on we're finding now that more and more companies, more and more states are shifting to the private insurance model for whatever reasons. Uh, Whether they are not finding it easy to manage, or whether private insurance companies are more efficient, or whatever. So many of the models which were there initially trust also are moving to the private insurance model, which is like lowest bidder model, typically our L1 model, which is used everywhere in the government. Now, this is where medical associations are heavily objecting, that you are getting into private insurance model. Private insurance person will always try to make money in the middle. You will always have less money available for the treatment. But the flip side of it is that the trust model, you will kind of sometimes do overcompensation of the treatment and spend a lot more money. And plus, we know how efficient government is at actually using funds, right? So that is another problem. So the efficiency of private enterprise versus public spending for public cause. This is the one of the conflict areas which many medical associations have with Ayushman Bharat. Now, what the government has done is about 1,500 packages of treatments were created, which are medical treatments, surgical treatments, and these packages were offered as a lump sum amount, to the hospitals for the entire treatment. So the hospital knows exactly what they will get for the entire treatment. Now, there are serious issues with these packages. We'll come to that later. But broadly, let's put it this way, that they took 2011 CGHS rates, 2011 CGHS rates, which are used in Mumbai, right? And then they went down on that 2011 rate by another 20%, and introduce that rate as, yeah, and introduce that
एक
rate.
मिनट, तो इन्फ्लेशन गवर्नमेंट की कैलकुलेशन में नहीं होती?
हाँ, इधर है, कर सकते हो, सब कुछ कर सकते हैं. And that is where the viability factor basically comes in for hospitals. So we'll come to that. It's very interesting that still most of the network hospitals are private. I will say about 55% private and 45% government hospitals in the network. What are government hospitals doing in a network like this, where government hospitals were already supposed to be free patients, right? People who are going to government hospitals are already going to be treated free of cost. They've always been receiving treatment free of cost. So why do you need to run the scheme in a government hospital which is already free? This is another question. So these are various issues which are there with the scheme. But the main question is why large scale treatment availability is not there in the majority of private hospitals, when net you can say that there is a surplus of beds in urban areas at least. uh, so why is there not a more widespread acceptance by the medical community? It is working well in maybe tier 3 cities. Tier 1 and 2 also, you will find not many private hospitals are doing it. You'll find it running in charitable trust hospitals, you'll find it running in medical colleges, but you will hardly find any purely private hospitals doing Ayushman Bharat.
Okay, just I would like to intervene here, Amit. So, it, to make sure that I've understood you completely. So, RSBY and Ayushman Bharat, to begin with, the major difference A first is the amount of coverage that was given. RSBY gave X coverage. Ayushman Bharat has definitely increased that coverage. Second is the amount of people that are being covered. Also, there was a definitional issue in the previous one, and they have kind of fixed the definitional issue. So now that we have covered that, but now I want to get into something very specific, right? So you just said that they chose the 2011 price rate as the baseline. They gave a rate that is below the baseline. Now I'm going to try to give you the government's argument, whether we call it a devil's advocate or whatever we want to call it, but I'm just going to try and give that. So the government is going to come and say that private players make a lot of money. Private players are what word should I say? They always work with a motive of greed, and they want to make more and more money and more and more money. There are enough ways, and then you'll find some random person saying, look, we found this hospital charging XYZ for this scam, blah 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 blah. So that is going to be one reason. But now let us stick to it. As you said, that most private players do not want to get into the scheme, but that's fine. But even amongst, as you so first, I would request you to tell me, even amongst the ones who are part of the scheme, there was something that shook me when you told me offline that major chunk of that money also goes into very specific surgery. So let's start there. Can you share that data first?
Yeah, so the large number of claims which are there, 2.2 about crore claims which have been registered under Ayushman Bharat till date, right? It's very interesting to understand the bifurcation on which this money is being spent. You know, now you would probably not believe that around 40% of the all the claims, all the amount which is spent on Ayushman Bharat is for one procedure, which is dialysis. So that's really massive. I mean, the problem of renal failure in India is huge, of course, and dialysis is an expensive treatment, about 25-30,000 per month on an average per person. And I will say, the amount of people taking dialysis facilities through Ayushman Bharat is crazy. It's a lot. Dialysis patients have benefited hugely, but the question is that does dialysis constitute 40% of the entire workload of the country? Obviously, it doesn't, right? But that one procedure takes up 39% technically, but okay, you can take it as 40% of all the resources under Ayushman Bharat. So this is one big question mark as to why it's so disproportionate. The next biggest chunk is general surgery in absolute numbers, 27% of cases. But as far as payouts is concerned, it is nowhere in the even the top five or top six. That's how low the packages are. Right. The next biggest contributor in the specialties is urology, which is there. Right. General medicine is also about 18%. So see the basically the cost of the treatment is a major constraint, but dialysis especially does very well because there are many people in dialysis doing charity work. Okay, there are big hospitals, there are big dialysis centers that are being run left, right, and center, which were at very very nominal rates. So this is all across. There are various dialysis centers that have empaneled, and they are running the scheme. Right. I know even the one of the hospitals I am attached to, which doesn't have any other thing as far as PMJY is concerned, has two dialysis machines for PMJY. Right. So that is one thing which is doing well under Ayushman Bharat, but it's disproportionate. Like cardiac surgeries is just 5% of the total business, total number of claims. The revenues for cardiac are 27%, and again, about 79% of cardiac surgeries are done in the private setups rather than the government setups. Now, why is there such a disproportionate thing? Now, in private, I will say there is also another problem we face, that the procedures which are even a little bit reasonably viable are not allowed in private setups. You have to go and get them done at government hospitals. So, that makes it even more challenging. Like, for example, out of the 1500 procedures in Maharashtra, around 500 procedures you can't do in a private hospital. You have to go to a government hospital only to get it done. So, government hospitals are actually doing good business with Ayushman Bharat, because earlier they would get nothing and each patient was an expense for them. But now they have some spare income from these. So, government hospital facilities, what they can offer other patients is better. But then it's the government putting money from one pocket into the other pocket, right? So the role, the ambition of this scheme was that we will create a lot of additional players as far as hospitals. People will open many hospitals across the country, so that catering exclusively to Ayushman Bharat patients. That's not happening. That's not going to happen. And the breakup is it shows why it won't happen, because most of the things are simply not financially viable. Why it becomes viable for medical colleges? Because someone else is paying, right? The medical students are paying. Why it becomes viable for charitable hospitals? Because they get charity from others, and because the government is forcing them to take it. The government is saying that we are giving you land for the subsidized rate, we are giving you water at subsidized rate, so you have to take it, otherwise we'll cancel your license. So the reasons why they have taken up the scheme are not because it's viable, but because someone else is paying for it. And that's where ultimately it comes on. In Mumbai, there are hardly two or three purely private hospitals who are running PMJY scheme. Now, I won't say anything more than that, but at least one or two of them have been repeatedly blacklisted also by various government schemes because of financial, you can say, frauds. But every single time they have to let go of it and restart the scheme in those same hospitals again and again. Why? Because no other hospitals are willing to take up the scheme. So it's kind of a case of, pay peanuts, get monkeys, kind of situation. That's what it is.
Okay, then in such a scenario, it's clearly a case that uh, the scheme, no, as they say, it doesn't matter how good your intentions are. Uh, uh, at the end of the day, a policy is as good as its implementation in the end, and how good it ends up working. And so I'm not doubting the intentions of the government. I mean, any government that aims to give healthcare to the underprivileged people should be applauded, whether it's Congress, BJP, it doesn't matter. But the point is, when you formulate a policy, it's about the second order effects, the third order effects. It is quite clear that private hospitals clearly are not interested in taking this up from whatever issue is there. And it's not like the scheme previous to Ayushman Bharat was a huge success either. It is quite clear that that there is this discrepancy, as you created three categories here, right? One is the purely private hospitals, the second are the medical colleges come hospitals, and the third are the charitable trust come hospitals. So these are the three categories that are there, and they seem to. So now let us get into the solution bit, Amit. So let's start over here. So obviously you gave three specific solutions in that tweet. So I'm going to ask you about your first one, where you said, number one, declare any profit made from it tax free. Now, what did you mean by that?
See, these rates are so low that no hospital is going to make a profit on it. You understand? So if these schemes are not, the government knows that the tariff is very low. They keep telling people, right, that think about the larger good for the society. But the fact is that any income from this scheme is taxable. They are going to deduct 10% tax. They are going to, while 10% TDS, while paying your claim in this meager amount also. The entire income what you get out of this is going to be taxable. The entire funds going to the doctors, whatever they get. I mean, it's literally whatever they get, because they may get 1,000, 2,000 rupees for a very big surgery. Even that amount is taxable. So why would anybody be interested in doing the cases, right? So you incentivize it by saying that, okay, we will forego the tax. At least some incentive has to go from the government side. saying that okay, we'll give you a tax break. I'll give you an idea why I'm saying this. I have taken some uh, you know surgeries where you will understand the kind of packages which are there under this scheme. Now we have a surgery like right, a big surgery like a bone tumor, which you are going to remove and excise and do a bone graft, right? What's the package amount? This is a surgery which in a private hospital will cost around 3 to 4 lakhs, because it involves a lot of super technical expertise. It involves cancer surgery. It involves a stay of 10-12 days. It involves a bone graft which you're going to have to procure from either a cadaveric bone or a prosthesis. The prosthesis cost itself is going to be massive. What's the package? 20,000 rupees. 20,000 rupees. Yes. Now, if you're doing a flap, a free flap, right? What is called as a free flap, that we call it, maybe not even a free flap. You can say rotation, flap reconstructive surgery. That's a supra major surgery, right? It may take as long as 10 hours. The package rate for a flap is 20,000 rupees. It's 7 days of stay, including at least 7 days of stay, including at least 2 to 3 days of ICU stay, including medicines, stay, surgery, आने जाने का खर्चा, 15 days after surgery का खर्चा, including what is patient before admission, 3 दिन तक जो भी टेस्ट वगैरह किए हैं उसका खर्चा. Now tell me, how viable are these rates, right? A surgery like a thyroidectomy, right, which is again a supramajor surgery, which will at least cost 70-80,000 bucks, is the total package is 17,000 rupees, right? So these are
How
the
does
kind of,
anyone work in this?
yeah, DNC, which is a very common gynec procedure, with it's 3,000 rupees. It's under anesthesia. What will the anesthetist take home? What will the surgeon take home? What will the hospital take home? And what will be the pharmacy cost involved? और आने जाने का खर्चा भी इसमें देना है, फोटोग्राफिक एविडेंस भी इसमें देना है आपको. How is it possible? I mean, this is kind of, doctors, I'm telling you from personal experience, doctors consult, think when they look at these rates, they consult it an insult to their profession that such rates are even offered to them. This is a fact. They consider it insulting to be offered such rates, because obviously, क्या मिलेगा उसको? I mean, he sits in his OPD and sees one patient and he gets 700-800 bucks. Or यहाँ पर he's going to do a surgery, take the entire medical legal risk, which doesn't go away. The medical legal risk still stays the same, right? You still pay tax on whatever you're getting. You get your payment after maybe 6 months or 1 year. And what do you get at the end of it? 300-400 bucks. Why will anybody be interested? So this is why I said that at least what the person is getting, you let it go as tax-free income. So at least the hospital gets whatever 500-600 rupees, वो तो कम से कम non-taxable हो, right? At least the doctor, whatever he makes from these scheme patients, whatever minuscule amount, considering, you're saying that, okay, you do some charity, then you treat it as charity, right? Why? What's the problem in that?
Yeah, okay. So now let's get into the second one that you raised. You say you should allow this activity as a CSR. I did not understand this. How would you go about that?
Yeah, so you make, see, the trust model, which many of the insurance, which was followed under the scheme. When you form a trust, you can take donations, right? So when the state and center is getting together to form a trust which will administer the policies, there's going to be a shortfall. They can enable, the big corporates to donate to that cause. So we are going to be treating a large number of patients, and that additional funds are available. Then that funds can be used to at least give the hospital some decent, remuneration, which is workable financially. One is that. Second is the corporates can directly, pay for medical treatments, and let that come under, supposing the treatment is being done at a private hospital, right? it's not going to be allowed under CSR. But if the person is doing an Ayushman Bharat, if the company is funding an Ayushman Bharat patient in a private hospital, that should be allowed under CSR. Maybe they'll not allow it under other things, but for Ayushman Bharat patients, if some company is sponsoring a treatment at a private hospital, they can allow that also under the CSR. So then, there will be some other person, third person paying for the funds for the patient, and it will become somewhat viable for the hospital concerned, for the treating team concerned.
I just have a query here. So what you're trying to say is, let us assume there is a surgery X. Now surgery X under the Ayushman Bharat tariff cost 100 rupees. Um, and that is not viable. So what you're saying is, let's say the government bears the 100 rupee cost, and then there is a CSR activity that comes parallel to that and adds maybe 100 or 50 or 25 depending on the surgery, and that makes it attractive and viable for the private hospitals to take it on, right?
No, you revise the tariff, no? So revise the tariff and create alternative ways of funding your scheme, is what I'm saying.
Yeah, but then don't you think the government is never going to do that?
That's because they've been told that the scheme is viable. One look at it and you know that this is not workable. I mean, come on, even in a rural area, this is not workable, right? जो I mean, material cost नहीं cover होगा उसमें. So I don't know why they have this thing that these are workable rates. They are simply not, and there is no logic or real. They say we've done extensive cost calculations. It's humbug. Nobody's done any cost calculations. People who don't have to run an establishment must have done those cost calculations, right? And there is a huge additional cost involved, by the way, for hospitals to run this scheme. You need to have a full-time doctor who's going to go to the field and get these patients enrolled and recruited. You need to have a social worker, right? Right. You need to have internet connection, a computer, and a network. You need to have additional manpower deployed at a counter in your hospital, right, for handling these patients. And if they're coming round the clock, then you have to have a person round the clock. You need a separate accounts team because to account for these patients is really problematic. You need a separate person to follow up on the payments. So you're talking about at least 8 to 10 additional people whom you have to recruit, and it's not that you can manage with your existing manpower. No way. You have to have at least 8 to 10 additional people, और उनकी सैलरी भी नहीं निकलने वाली है इनसे. So, how is it going to work out unless the tariff is revised? I'm saying that to create additional funds, the government has to think of uh, creative ways. One way you said that they say that whatever amount X, companies matching that amount in contribution will, be that fund will be treated as CSR. But the easier way will be just to revise the tariff and accept donations. Then you can at least pay others. If you're saying that we don't have enough funds, with this is all that we can pay, then you create additional avenues for that income. You disconnect the private insurer model completely. But private insurer model won't be discontinued. In fact, as I said earlier, that most of the states are actually moving to this model, and it's going to get worse. For you realize what happened under RSBY scheme, why 12,000 hospitals came down to 8,500, and why 3,500 private hospitals walked out of the scheme within 3 years. They had not been paid for more than a year, sometimes 2 years. The charges I already told you. The charges were, yeah, they don't, even the CGHS schemes and all, they don't pay. एक एक छोटा छोटा पॉइंट निकालेंगे, ₹5 का मिस्टेक कहीं पे होगा वो पकड़ लेंगे और आपका पेमेंट गया 6 महीना. So, this is where the things are as of now. So you have to increase the payouts. One, second, you can increase the total funding which is there, right? And allow matching contributions. Now, supposing you don't want to pay at all from your insurance scheme, the whatever X amount of treatment is there, some other corporate will sponsor that treatment. Let them pay, and you allow them as CSR. So the money is not being paid by you. The money is being paid by someone else, right?
Hmm. Okay, so let me play the devil's advocate again over here. So somebody might come and tell you, Amit, that you are misunderstanding the ultimate aim of this scheme. The ultimate design of this scheme is a, it is a volumes game, because when you treat people in huge volumes, the economies of scale crop in. And so hear me out here. I'm going to try and give you a detailed reply to this. The as and when the economies of scale come in, you have a case where economics 101, prices should come down. So all these private hospitals should be in a position to take care of that. Number two, the aim of this scheme was not to design it from the point of view of the hospitals. The aim of this scheme is to design it from the point of view of the patients, the poor people in India, and all those places. Also, what if somebody says that maybe it is not running well in Maharashtra, but there are states in India where these schemes are running well. So in those cases, Amit, so I've given you a detailed answer what might come from the other side. What would you tell then?
So now, you, as far as this argument of economies of scale goes, it's a false argument as far as healthcare is concerned. And I'll tell you why it's a false argument. Because if I have X number of patients, right, my doctor to patient ratio, nurse to patient ratio, right, ICU nurse to patient ratio are prescribed by the government, already fixed. Okay. So if I have 20 patients today, I require in a ward, right, maybe 18, I can say. You need three nurses, right? One for every six. You need again one for every 10. You need a doctor, right? If in the ICU, then you need 1:2. So one nurse for every two patients. And this ratio does not change irrespective of what the patient is paying. You get me? You have fixed, ever increasing overhead cost, which is going to increase as much as your volume increases. So your salary burden will increase. Your electricity bill, water bill will proportionately keep jumping up, because the more number of people are there, the more the electricity, the more the water utilization is going to happen, right? It's only your maybe land cost and your EMI cost which doesn't change, but your other expenses will keep rising in proportion to the number of patients that are there in the hospital. So economies of scale is good for manufacturing. In a service sector like ours, which is so labor intensive, it makes very little sense to claim that economies of scale are going to kill. You revise the norms and you allow people to violate this patient doctor ratio, then things will work. But if you want to maintain, the and it's not, I'm telling you, government hospitals don't follow this ratio. It's only for us. गवर्नमेंट हॉस्पिटल्स में मैंने काम किया है, साइन हॉस्पिटल में 50 पेशेंट के वार्ड में एक या दो सिस्टर रहते थे. These rules are only for private players. Where are these rules being applied for the government themselves? The government hospitals, you show me which government hospital has got one nurse for six patients. No hospital will be having. You show me one government hospital which will be having 1:2 ratio in ICU. Not one of them will be having it, and they know very well that kind of ratio is not possible also, right? It's not financially viable also. Unless you're running houseful, you simply cannot afford it, even to pay the bill, right? So as far as cost is concerned, the cost is going to increase in a linear manner as far as these schemes go. And the more number of patients you have, the higher is your running cost. There is no economy of scale. If you're making a small loss in one patient, you will make a big loss in 10 patients. And that's it. You are not going to make money out of this scheme. At some point, you may think that you're going to make some money, but you realize that your payments being held up for 6 months or 1 year, and primarily you already faced a tax deduction upfront, which you have to wait for another year till you get your tax refund, right? 2 साल तो तुम्हारा पैसा वैसे भी नहीं आने वाला है. कोई भी स्कीम आप कर लो, इतने कम रेट्स में 2 साल पैसा नहीं आएगा तो कोई चला नहीं सकता, right? That is one basic thing. Now, second thing, designed for patients. If it's designed for patients, then patients should have the option of at least going to multiple hospitals for treatment, right? Why should a patient who is enrolling for these schemes because he doesn't want to go to a government hospital, he wants to go to a private hospital and get treated, right? 70% of all hospitals in the country are private hospitals. He wants to take treatment at a private hospitals, but your scheme allows him to take treatment only at a government hospital, which is already overcrowded and overburdened. How did you benefit him, right? If you are saying that the scheme is to benefit patients, it is to benefit patients. No, I'm not saying that it's not benefiting patients. It's benefited a lot of patients, especially as I said, dialysis patients, cardiac surgery patients, and a few other specialty patients have, some cataract surgery patients. There are patients who have been benefited by the scheme, definitely. But when you look at the way that it could have potentially been beneficial, and you look at what's actually happening, I mean, I don't see any reason why you should say that, okay, these 600 in Tamil Nadu, 680 procedures can only be done at government hospitals, right? Private hospitals can't do that kind of numbers. That is literally, 45% of all the procedures that you've listed out. So, you know, you get my point that whatever procedures are financially viable, you won't allow those procedures, right? But what are not financially viable, you're going to expect private players to do it. That is one thing. So how are you benefiting patients by squeezing these rates dry? You're not leaving hospitals with any margin in case something goes wrong with the patient. There is no provision in these for something going wrong and you requiring additional stay. The burden straight away comes on you, right? There is no provision for emergency charges in case the patient lands up with a critical emergency requiring further hospitalization, requiring an ICU stay. It's all included in this amount. They're not going to pay you 1 rupee more also. I had a patient who came to my hospital on a Sunday evening with severe bleeding, and the patient required an emergency cesarean section. The patient was hepatitis B positive. They paid only 11,000 rupees for the entire treatment. That also after 2 years. So how does this thing work? I mean, it's not surprise that people realize. And if you say that this is good for the patient, how is it good for the patient? It's not, right? Now, the third thing you said is that uh, the scheme is doing well in some states. Yes, the scheme is doing well in some states. The scheme is not doing where the healthcare is uh, was not very great. The scheme is doing well, but if you look at the procedures that are being done, right? The states which are considered like northeastern states, the coverage is very good. Some states, and even in the northeast, have got a fabulous coverage of more than 90% of patients are opting for treatment under this. In similar area, there are not even 30% in the other states. So some states it is doing well compared to other states. There must be some local factors involved where they are able to they have a very low running cost involved because the salary burden, the smaller places you go to, the salary burden is comparatively very low. Whereas in a metro city like Mumbai, the salary burden is very, very high. So when you go to, that's why I said, if you remember tier three cities, tier three is the only place where you can expect these schemes to work. Tier three and rural hospitals are the only place where you can expect because their salary burden is very low by comparing to a metro city like Mumbai, where the salary burden is huge. It's huge. I mean, जो nurse कोई rural area में 5-6 हजार में काम करेगी, we will be paying that person 25-30,000, and there is no provision for a cost difference in area to area. The other thing why it can be doing well in some states is because of integration with the existing local scheme in that state, which is offering better tariffs. So that differential tariff goes directly from the state government. If the state is offering a tariff which is higher than the PMJY tariff, the central government will pay 60% or whatever they've agreed up to the amount which is contributed in that PMJY rate, and the balance amount the state funds out. So many of the states, actually, the schemes are very good. Like Andhra, the scheme is good. Karnataka has got a good scheme. They have integrated at PMJY, but the package remuneration which they are giving to the local players is higher, considerably higher than what is being paid under PMJY. So that is one thing. But then the additional cost hit is taken by the states, and it's not completely funded as it is in these cases.
Okay, so now let me take a couple of questions, Amit, because we want to talk about Omicron, the Mogambo variant also. But before that, I want to take a few questions. So, somebody has made a comment question. I don't know how to say it. So, someone says pricing is a double-edged sword. Do we want prices increasing so much like the US? What's the balancing act between market forces and government price control? That is the first question. And then they add a comment saying one of the failures of Obamacare was that private insurers were running losses cause of Obamacare because there was no price control. These insurance in turn sued the US government to pay for those losses. And also, I remember clearly in the case of Obamacare, what had happened was because they had to cover up for patient A, they ended up hiking the insurance rates of other patients. So somebody else was paying for someone else. Now, honestly, in a socialist world, a socialist would say, yes, you're supposed to pay for them because you make more money. So, what would you, how would you balance out this, Amit? The comment made by this viewer.
So the whole concept of insurance is this only, no? That someone else pays for your treatment. That's how insurance works, no? Because 1,000 people paying for one person's treatment in the hope that they may be that one person. Right? So the premium is collected from 1,000 people, and ultimately 1 out of 1,000 requires treatment. That's how insurance works. That's how the model itself is. And in the US, it's highly commercialized compared to India. Uh, and the insurance companies have actually ended up driving the cost of treatment way higher than they should. And I'll tell you, as a rule of thumb, uh, if someone else is paying for your treatment, they will pay more, right? So this is one problem which the insurance companies will keep facing, because more people will go for treatments which probably they could have avoided if they were wanting to pay for it themselves. I'll give you an example. What sort of things are covered, right? The LGBTQ movement, and what's happening in campuses where transitioning happens without even informing the parents that your child is transitioning. All of the treatment, including injections of testosterone, including sex change surgeries, is all paid for by the insurance company, not by the patient. Okay, and that also the university is buying the. So there is a lot of wasteful, criminally wasteful expenditure that was totally avoidable, which is being done. The payouts are also reducing for doctors and for other procedures also in the US. But when technological advances keep taking place, it's difficult for them to comment. The for pharmaceutical cost is way, way higher than what it is here, right? Like you can buy 100 tablets in India for what you would get one single pill in the US. So there is, in short, what I'm trying to say is that the US model is an extremely highly inflated model as far as healthcare is concerned, and there are a lot of factors because of which that happens. Because people get sued also proportionately. They get sued for millions and millions of dollars. Be large corporates get sued for hundreds of millions of dollars. So uh, from where will that money also be accounted for? At the end of the day, somebody is going to pay for that, right? And if you're going to give millions of dollars to each patient who's ended up with a problem, you will eventually end up distributing that cost over all the other people who require treatment. No? That's what is going to happen. And that's what is happening. The lawyers are the ones driving the cost up. In other words, pharmaceutical cost can come down, but the number of regulations they have to comply with are huge, right? The research costs involved in the US are very high, right? Primary research costs involved are very high, and also there is a very little governmental control, because a lot of these corporates actually are funded by the government. They take research money from the government and then eventually don't pass on the benefits to the end user. And by and large, the US governments have been sitting on it because the pharma lobby is a very, very powerful lobby over there. So they are, they have more or less, you can say, been responsible for the mess that they are in right now. And I don't see them having any solution, because the way the healthcare is structured, healthcare cannot really be capitalist. It doesn't work that way. You have to have kind of some element of control if you want to enable public to get treated at a cheap cost. The Indian model is, you can say, very, very opposite to this model, where traditionally the low cost healthcare players have been the ones providing most of the healthcare. And that model is now getting distorted because the government thinks that larger hospitals are better and can reduce the cost. But have they really reduced the cost? No, right? What procedure can be done at a small nursing home? A large hospital is going to charge you more than that, right? Because they have a larger infrastructure to maintain. So there is a kind of distorted perception. One, as you said, the economies of scale, it doesn't work in healthcare. The larger hospitals end up paying more than you would, right? In insurance companies stepping into private healthcare in India also, there are a lot of challenges because uh, you know there is no literally place where if the claim is not if the insurance company today gives me a payment guarantee and tomorrow says I'm not going to pay, there's no place where the hospitals can go in appeal also. I mean, that's what the current situation literally is. So insurance companies in India work very differently from the ones in the US as of now. Eventually, and in fact, insurance companies may even dictate what treatment is to be followed in the US. They can't dictate over here. So there are very big fundamental differences. The insurance model is not a good model to follow. In all fairness, I'm telling you, public healthcare is a much better model to follow. I will say the NHS model is a way better model to follow, but it is very inefficient because your appointment systems are very delayed and everything by comparison. So US model is not a good model as far as healthcare is concerned, and certainly not one which India can afford to take. So that's why, if you realize what Devi Shetty had said long back, is that cap the amount of compensation potentially payable under Consumer Protection Act. He had said this many times. He said this, that you cap it, because if you want to keep the overall cost low, you cannot afford to make the same mistakes that US has made, or maybe other countries have made, because these things, every little bit is going to go on adding to the cost. So there are a lot of ways to in which this can be worked out.
Got it. So just to summarize, Amit, because I want to talk about Omicron too. So just to summarize, so what I've understood from this is, as of now, the aim of this podcast was not to say whether Ayushman Bharat should be shut. The aim of this podcast was to say, look, we think these are the shortfalls in the scheme. The intent of the scheme is actually laudable. If you tweaked it here and there, maybe there would be a pickup. If you think it is perfect, fine. There are hospitals in India that are running currently on the scheme of Ayushman Bharat, doing whatever they are. They might go on running it on that scheme. Now if somebody it's not like you have to run on Ayushman Bharat. Yes, the state governments do try to pressure private players in their own ways, subtly, to get on board, but eventually, not every private hospital is going to get on board, and that now the onus is on the state. If they're not able to convince a huge chunk of the private players in the marketplace of India to get on board with this scheme, then has to be something wrong, and you cannot put everything down to greed. And I get that. And not has Amit suggested that this is a bad scheme or anything. All Amit is saying that if you could make these changes, and maybe, if you present new data, Amit might change his mind. So, you can contact Amit on Twitter. You can send some new data across to Amit, and Amit is a very open-minded guy. If you show him evidence, he might even change his mind. But Amit, now let us get into the new Syapa, as they say in Punjabi. So, Abhi, what the hell is going on, Amit, as far as the Omicron variant is concerned? So, what are your views on the state of affairs right now? So, I take it up to you now.
So we already have a very horrible variant called Delta over here. So it's done whatever damage it could. And I don't think there's much that is left for Omicron to do over here now. Right? So what I'm saying is that, see, our vaccination program has gone good. Uh, Most of the second doses which were given, in fact, even a lot of the first doses which have been given are actually in the second half of this year. no one, most of the, the population which has been covered has been from May onwards when the vaccination program really picked up. And that's actually not even the second dose is, most of these cases is not even 4 months back. So I don't know why we are even talking about a booster for the entire population as of now. We haven't even given the second dose to about 40% of the eligible population yet, right? Now, maybe you can say the now why I'm bringing up the topic of booster right away, because people have been constantly bombarding that Omicron aa gaya, booster lagana chahiye sabko. Which is nonsense. First of all, we aren't using mRNA vaccines, which will disappear from the system in 6 months. mRNA vaccines, those who have been using, and that also particularly Pfizer, there is a problem because the efficacy really falls fast. I wrote an entire article on this as to why, and in fact, today in the ICMR uh, press briefing, they repeated quite a lot of what more or less similar lines to what I had said. That the mRNA vaccine seemed, and especially Pfizer, because it's a low dose mRNA vaccine, tends to lose its efficacy very quickly because the immune system isn't responding that well to it. T cell immunity isn't really happening very well with it. Whereas, a vaccine like what we are using, AstraZeneca or Covaxin, are comparatively, the immunity is showing up at least much later also. Out of this also, I will say that Covaxin, Krishna Allah has said that he would be very happy if one booster additional is given at 6 months. And Covaxin being an inactivated whole virion, it kind of makes sense because the efficacy generally for whole inactivated virion is slightly lower generally. So for this particular vaccine to be given as a booster, it's an extremely safe vaccine. So I think the booster also should be fine. But as far as AstraZeneca is concerned, when the second dose itself is being given so late at 3 months, how can anybody say that in another 3 months the efficacy will be gone? Because the reason why you're giving the second dose at 3 months is because the vaccine, the first dose, is supposed to work very well for even up to 3 months, right? Now, Delta being a much worse strain than Omicron from all the data that we are seeing right now, Delta looks like a much worse strain than Omicron. Omicron, the most of the cases are actually comparatively mild, very few cases in the ICU, and only one reported death from Omicron, which was in the which was in the UK till now. Out of some, I think, what, 27,000 cases in the world till now. So, for all practical purposes, Omicron is showing up as a milder disease, right, as of now. For being worried about a milder strain and panicking and giving boosters to your entire population, I think it's kind of silly. Uh, the high risk population will need boosters eventually, right? People who with comorbidities, people who are very elderly with a little poor immune response, people who are immunocompromised and don't have adequate response, these people you will need to give something additional for ensuring that they are okay. But I don't see any much problem with Omicron as such. The same medicines work, the same tests used to diagnose them, right? And a milder course in general. So I don't know why people are freaking out so much.
Just to add one more question to my query over here is I'm really confused. So today I read a Bloomberg article which said South Africa hospitalization rate plunges in the Omicron wave. This is written by Anthony Swazin. It was December 17th, and I'm reading a quote. Quote, only 1.7% of identified COVID 19 cases were admitted to hospital in the second week of infections in the fourth wave, compared with 19% in the same week of the third Delta driven wave. Then now I'm completely confused, because then there was this Imperial College study from UK that says no, in the UK the results are different. Now, Amit, my question to you is that now yesterday I just checked. See, this is honestly playing with people. So everybody was like, UK records 86,000 or 89,000 cases yesterday, और सबको डरा रहे हैं बैठ के. Nobody said they have increased the number of testing. They're literally testing more. I am not against testing more, by the way. That is a good thing that they're doing. They're trying to cover a larger area of their population so that they find out the spread. But the real target, what I have not understood this in the entire COVID discussion. Our target should not be the number of COVID positive cases we get. Our target should always be on a week on week basis how many deaths and how many hospitalizations we get. Major amount of people are vaccinated. Vaccines were never going to be 100% effective. Anybody who thinks like that has some issues in life. But the point is, then why are people not being educated in the proper way, Amit?
Yeah, I mean, it's high time we stop testing asymptomatic people. This happened in recently in Maharashtra also, where 50 policemen tested positive in one go because some VVIP visit was due to happen, and everyone was tested, and 50 asymptomatic cops tested positive. Right, they were all asymptomatic, fully vaccinated people. None of them had any problem whatsoever, actually, right? None of them ever became symptomatic. So why exactly are we testing asymptomatics just to? I mean, this is at the end of the day, even for Omicron, how did they detect so many cases, right? In the South Africa, about in the early days, about 66% of people who were diagnosed as Omicron positive were actually admitted for some other treatment, and they were as a routine being sent for COVID test kar lo before this procedure is done, and they all tested positive. So most of these guys are completely asymptomatic, and I don't see any reason why you should be really going after the absolute numbers. Even in the UK, you look at the number of admissions. It's not gone up by much. I mean, the number of positive cases, if you have 70, 80,000 cases a day and your admissions are 700, 800, what percentage is that? 1%, right? And that's just the admissions, and mortality even lesser than that. And this is a country where the mortality itself was over 2%, right? In UK. So what exactly is being achieved by testing all these asymptomatic people? Really, in all fairness, nothing much is actually happening to them, right? So they have the virus in their system and they are completely fine asymptomatic. That means the vaccines are actually working well, right? Why this response? I mean, okay, I have seen the chart of the UK government which says that AstraZeneca is not effective against Omicron. The efficacy has fallen down sharply over 6 months, but that is for the overall number of positive patients alone. Like how many vaccinated patients are tested positive? It's not the moderate severe cases at all. That moderate severe number is extremely low. It's compared to what it used to be. The number, I mean, come on, that country was having 1,000 deaths a day, and it's not even having 800 admissions a day now. That itself tells you the story that people aren't really getting that. There are people who are getting sick, no doubt. I'm not saying nobody is getting sick, but the numbers are really less. You know,
Okay, so somebody has asked this question, Amit. Someone has asked, is Omicron going to be the variant that kills the Delta with a higher infection rate and a much lower in lethality? I mean, if you say we can't say with surety right now, I'll totally understand, but मैंने फिर भी question पूछ लिया.
from all the things that we have in hand, that's what it should be. I don't know whether it's going to kill Delta or just implode on its own. That only time can tell. Right now, in many countries like South Africa, 90% of cases that are being diagnosed are Omicron. So it has a potential for explosive spread. But I mean, really, what is the absolute numbers? Really, how is that going to change anything, right? So if your number of cases, even in India, today in the ICMR presser, which the central government said that if you look at it in proportion, what's happening in France and in UK, if we have that many number of cases with respect to our population, it would come to around 15 lakh new cases a day, right? That's a very, very huge number, and they would want to avoid it because 15 lakh new cases a day means, even if you take a lower side, 15,000 hospitalizations a day, and you don't want that, right? So they will follow whatever protocols have to be followed, and we should also follow whatever basic protocols we've been following, right? uh, but beyond that, I don't see any reason why we should be really freaking out, because the last time we had that kind of numbers, we had a much worse situation. And most, as I said, most of our people are freshly vaccinated. I really don't see why we should be so worried.
So there is another issue when it comes to this whole vaccination saga, Amit, that we need to talk about. This is something where I personally don't know what should be done, but kids. Now America is clearly vaccinating everybody 11 and above. Do you think India should also vaccinate children 11 and above?
No, categorically, I'm saying no, because only the high risk kids who have serious diseases or disorders, you need to vaccinate them because they are high risk. This is the only subgroup of children which actually is landing up in the hospital because of COVID. No other healthy, normal, jumping around child is generally landing up in the hospital by and large. And the mortality in children is as low as 0.002%. Okay, so it's extreme, and that's for Delta, not even Omicron. So now that's one in, right? It's very low, right? How much does that come out to? It's really less, right? It's 1 in 20,000. Now you consider this, that in the West, why there is such a big uproar about it is because mRNA vaccines are being given to kids. The chances of myocarditis is 1 in 10,000 in young male population. So how are they helping kids? They're not really going. So I'm not keen to vaccinate kids at all, except the high risk population. Okay, once they are somewhere close to adulthood, 16, 18, then you can give them the vaccine. But I really don't see any role of vaccinating kids as of now. And I don't think the risk benefit ratio matches up. Children get COVID and they do not have, by and large, any symptoms at all. They have fever or cough, cold for a day or two. And beyond that, usually they are almost asymptomatic after the first 2 3 days. And some systemic inflammatory response cases have been definitely reported. And while in the second wave in Mumbai, all the hospitals were overflowing terribly, the IPCUs were also full. This is one thing which people don't probably know, that intensive care units, pediatric intensive care units, were also running full, but they were never overflowing. And despite running full, the mortality in them was extremely low. So really, children are very low risk for severe disease, right? And I don't think there is too much of a role for vaccinating kids as of now. If at all something has to be given, Zycov can be given, Covaxin can be given. There is certainly zero role of mRNA vaccines or Covishield in young population. There is no role. These two at least can avoid. But by and large, if you look at it, I don't really see much of a role for vaccinating kids.
Okay, Amit, one more thing I had a question about. There is a lot of discussion about this. I don't know why it receives such an angry response from so many people. This is a question of natural immunity. Now, you and I have a common friend, Jemin, who got COVID when he went to Delhi. Now, Jemin got COVID, and Jemin, I'm sorry, मैंने तेरा नाम लिया. अगर तुझे पसंद नहीं आया, मैं एडवांस में माफी मांग रहा हूँ. दो गालियां दे देना ट्विटर पे. But the point is that Jemin got COVID, then he was fine, he recovered fully well, and then he took the 2 doses. Now, this whole booster fetish, and also this whole thing about the strategy of tackling COVID. Now, why is natural immunity through I am not saying जाके COVID ले लो, obviously, मगर अभी हो गया तो क्या करे, हो गया जिसको तो हो गया. Now, in that scenario, why is so there are so many studies in Israel that clearly show natural immunity tends to last longer. In fact, I had if you remember, Amit, I had shared you a whole link of all the reports of natural immunity that people are gathering around the world. Now, I get it, I take it with a pinch of salt, and you had told me you should also take this with a grain of salt. But it's not like immunity towards COVID is only going to be through vaccination. Why can't hybrid be considered? So in the case of boosters, how can you make something like that compulsory? What if somebody had 2 shots, they got COVID? Aren't they as good as getting a booster in that scenario, and why is this resistance?
Yeah, so actually, people who have already had COVID should be treated on par with vaccinated people. I don't think we need to vaccinate them again, because it's now pretty much accepted that people who have had COVID are very low risk for getting a recurrence or a relapse of the disease or reinfection also. That's very low. It's like 1 in 2000 people. It's very low, 0.2, 0.3%. Very, very, very low numbers. So, I don't think there is any, real problem in considering people who have already had COVID as uh, on par with fully vaccinated. You don't need to go around vaccinating them again. For the again the high risk population, in them you can give a booster dose. One shot of vaccine can be given additional, but again, two doses also I don't think are required. Now, all the studies which have been done also on one dose vaccination after COVID have said that this is very much more than enough, and one vaccination dose after a proper COVID infection is better than two doses of vaccination given. But again, these studies were mainly on mRNA vaccines, which we know now are really the efficacy does fall afterwards. So yeah, there is a I mean, all immunity is natural, right? At the end of the day, whatever immunity you're getting is natural immunity only, because the body will react exactly in the same way to the spike protein in the vaccine as it will to the spike protein in the virus itself. So that if the mechanism is the same, the production is, except that the number of points on the surface of the virus which are going to be identified and attacked are going to be more in a in the original thing. But also you're taking the risk of the disease, right? At the end of the day. So natural immunity, all immunity is natural, but when the original thing comes in front of you, obviously that the body will react a little bit maybe differently, you can say, because it will have multiple points on which to attack compared to just the vaccine, which will be a limited. So even in the inactivated whole virion is the concept is that only that you're presenting the entire virus, so the immune response is better and of a superior quality. But again, that virus is inactivated and killed, and it's not an intact virus, right? It's uh, it's uh, so so that also may be slightly lesser in efficacy as far as that is concerned. But yes, natural immunity is a real thing, and all immunity is natural immunity. But getting COVID is definitely, it creates a long lasting immunity, there's no doubt. And if you look at SARS-CoV-1, with the original SARS-CoV-1 virus, people who had SARS-CoV-1 showed good titers of antibodies in as far later as 17 years. So yeah, I mean, you do get long-term immunity. So I don't see any problem as far as allowing people, who are post-COVID to be on par with vaccinated people. So
Also, what do you make of the zero surveys across India? X number of people have antibodies, Y number of people. There is one side that says we should take them with a grain of salt. The other side says they are not valid at all. So what's your view on the entire zero survey thing?
I don't know why people say it's not valid. Yeah, of course it's valid. I mean, you look at the way polls are, the exit polls are conducted. You do a survey of 5,000-6,000 people, and then you make projections for an entire state, right? And they get it right most of the time, right? So yeah, and this is much easier than that because the complexities involved are much fewer, right? In that, if you have to tell caste, you have to tell age, sex, this, that, and यहाँ पर क्या है factors? कुछ नहीं, खाली positive या negative. So I don't know why people think that representative samples are, not reliable. They are pretty reliable actually. And इतना gross error नहीं हो सकता है. Like Mumbai जैसे city में non-vaccinated population is 79% of them are showing antibodies, and vaccinated population 90% are showing antibodies, right? So I mean, that kind of error can't happen. It's too big. It's too much for being an error. Like in Gorakhpur, 98% of population has antibodies. Literally every single person you tested. How can you say that it's not right? Right. So I think antibodies we can safely, and at the end of the day we are seeing, in Mumbai the first wave all the slum areas were hit, and the second wave slum areas were hardly affected. Right. Mainly the building people who were affected. The slums were not that badly hit by comparison. So we are seeing that happening also. No? So I don't know why there is no real discrepancy in what we are observing and what the Zero survey is telling us.
Okay, one more question, Amit, and then maybe we'll wrap it up. So somebody has asked, is long COVID still a thing? And then they ask, was it because of a person's immune response or due to wrong medication?
No, it's not because of any wrong medication or anything. Long COVID is a real thing, and many people. It's not only with COVID. You get these sort of chronic body ache, joint pains, illnesses, and even psychological disturbances and a lot of other things. You get these sort of things in many types of viral infections. It's not only COVID, like the most notorious being chikungunya, where you can develop crippling arthritis over a lifetime, just by having chikungunya. So it's not something which is uncommon even for other diseases. So long COVID is definitely a thing, and even people who have had mild disease can get long COVID. Brain fog is a very real thing. A lot of patients with COVID have complained of brain fog. It's very real. The feeling of weakness, the feeling of shortness of breath for many months is very real, right? The lung damage, which is visible on scans, goes away eventually, but there are consequences to this disease. Though eventually, maybe 6 8 months down the line or a year down the line, most patients are going to be fine. Very few will have long-term debilitating problems beyond a year. Generally, 6 months, most of the people should be come, but definitely long COVID is a thing, and it's not the only disease in which this happens.
All right, Amit. Before we wrap today up, I would request you to tell everybody a bit about the charity work that you guys do at PEL. So, because I've already left the link in the description of the podcast also, but I do want to talk. I want you to talk about even a recent video that you shared on YouTube. So, can you give me a basic idea and how people can go and maybe even check the work out and if they want to contribute to the process? So could you tell us a little bit about that before we wrap today's podcast?
Yeah, so we have a small trust called PEL Services, and through that we mainly concentrated on education and health over the years. Education, health. After that, we've added, of course, livelihood generation, child abuse and neglect also. But most of our activities are in the field of education and health. And we've been on the COVID front lines over the last now almost 2 years, and we saw firsthand how families were getting destroyed. Literally, people losing multiple family members, people losing the main breadwinner in their house, and it was extremely traumatic also to watch this happening. And like my better half is the one basically who drives the thought behind it, and she was also extremely upset, and हम लोग ने सोचा कुछ तो करना चाहिए हम लोग को इसके लिए. So since our forte is education, we thought, okay, we will support the kids who have lost either one or both parents to COVID. And then we started this initiative called Project Sharan, and under which we started supporting the education of these children and paying their school fees. Eventually, we ended up paying also college fees for some children, and also sponsoring their books, sponsoring their stationery and other things, and in some cases even paying for the where the schools are functioning, then even paying for the transportation, school bus and other things. The idea is that we don't want any kids to be left out of school, and already up to about 117 beneficiaries we have managed to help. We had initially thought that we'll try to help around 100, but actually we ended up around 117 till now, and the numbers are likely to go up further. And so this is where the things are, and this was done via Google form, which was circulated along social media as well as among the population at large. Uh, so this is an all India project actually. Project Sharon is an all India project. So we have most of the beneficiaries are in the two states where we do our maximum work, Maharashtra and UP. But also we have people from other states who have been benefited. Some kids in Rajasthan, some one person from West Bengal. So there have been people from other states also who have been benefited. But most of the beneficiaries are in these two states. Of course, you're most welcome to contribute to it. You can just go on the website and you can contribute via website, or you can contact me directly if you don't want to, if you want to, uh, help us identify more people who have such a requirement, because we are very specific. We are, supporting for people who have lost their relatives to COVID, the children, right? So जनरल पब्लिक को हम हेल्प दूसरे तरीकों से कर सकते हैं इन अदर थिंग्स. This project is very specific for COVID. So other things that we do is we support around 500 children for their education. These are children in the state-run homes. Then there are children whom we support at. We are doing a community education project, which is run at a temple complex in Lucknow, which is called Buddheshwar Temple. So there we teach the children of the street vendors who had fallen out of school, due to the lockdown. So since the lockdown, we started taking classes for them. So that also project is going on very well. And then in one of the homes in Lucknow, where we were working with the girls who are mainly Poxco victim girls, we started livelihood projects over there also. So tailoring, embroidery, and beautician courses are being run over there. So a lot of good work is being done, and it's.
Awesome. All right, guys. So if you want to support Amit and the work they do, I have, as you saw, I shared the link of the website on the screen itself. But I know some of you or many of you listen to the audio version. So, any case, in the description of this podcast will be the link to the foundation where the work is done. I have personally seen a lot of work Amit and Anjana, both of them do. It is excellent. I would request each and every one of you to go and support their work. These are good people who do great things, and I've learned a lot. Knowing them over the years about the problems people face, and you know what? Even when it comes to Ayushman Bharat, I say this again. Here, Amit points out if you disagree with Amit, you know, again, Amit is there on Twitter and on many other social media platforms. Reach out to him, tell him, Doc, this is the data that I find out. Now tell me, what do you think about it? And Amit will give you a hearing. The aim of this podcast was not to criticize the government. The aim of this podcast is to make sure that the policy and the intention of the government with which they design a policy, which is for the success of a policy, it should actually do that. So we'll wrap today's discussion up. Amit, as always, it's a pleasure talking to you. Thanks a lot for coming.
Thank you very much, Kushal. And it was really a nice discussion, and hopefully we'll catch up again.
All right, guys, time to end today's podcast. As always, if you like the podcast, please subscribe to the channel, like the video, leave a comment, go follow Amit on Twitter, go and check their work out at pehel.co.in, support their work. If you want to support the podcast that I host, well, please become a member on YouTube, go and become a subscriber on Patreon, or buy the merch, or send your donations through UPI. I will see you next week with another discussion. Until then, namaste, take care, goodbye.